This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
The next speaker is Hallie Prescott, and Hallie was the first female who was awarded it, which was very exciting for us, so we think that that's a fantastic thing, and she should be highly congratulated on that. And so Hallie has overcome the difficulties of having poor mentorship and should provide a wonderful chance for anybody in the audience who suffers from having a poor mentor. And she's provided some fantastic papers in the last 18 months to 2 years on looking at severe sepsis and so forth and the longitudinal effects using epidemiological work. So it's fantastic that these two talks are sort of somewhat different, but they're both high quality, so we're really looking forward to your talk, Hallie.
So far, so good. All right. Thank you for that introduction, and also thank you to the organizing committee for inviting me to be here. It's been a really fun conference for the past 2 days, and it's a huge honor to be able to present my work here today. My only disclosure today is that the views expressed in this presentation are mine, and not the views necessarily of my employers, the Department of Veteran Affairs and the U.S. government. My talk today is going to be focusing on 3 topics. First, healthcare use broadly surrounding a sepsis hospitalization. Second, specifically looking at hospital readmissions. And third, looking at early and then later mortality following a sepsis hospitalization. All right. We know that the incidence of sepsis has been rising over time. This figure here shows the incidence of sepsis hospitalizations among U.S. Medicare beneficiaries on the blue line. So you can see that this has been rising rather dramatically over time, in contrast to relatively flat or even declining rates of hospitalization for acute myocardial infarction during the same time period. And this trend is seen throughout the world. So here in New Zealand and Australia, the incidence of ICU admissions with severe sepsis per 1,000 inhabitants has similarly about doubled over the same time period. So we now have a very large population of patients each year hospitalized with sepsis, and many of these people survived a hospital discharge. And earlier studies had suggested that the amount of healthcare dollars that we spend on patients in the year after sepsis is very high. But this information existed a little bit in a vacuum, so there was no understanding of sort of how did sepsis actually change people's healthcare utilization? What did it look like before the sepsis hospitalization? And so to examine this question, I looked at healthcare use in a cohort of about 1,100 patients with a sepsis hospitalization in the late 1990s through about the mid-2000s. And all of the patients in this study were participants in the U.S. Health and Retirement Study. This is an ongoing, large observational cohort study that now has over 35,000 people who have participated. And all of the people in this large cohort study have detailed survey information every 2 years, so we have a lot of information about them. And in addition, for those who are over 65, we also have access to their Medicare claims. And so those are the patients that I used for this study. I pulled out the about 1,100 patients in this larger cohort who had had a hospitalization for severe sepsis, and then I measured their healthcare use in the year leading up to and in the year after the severe sepsis hospitalization. So in this figure, the x-axis represents the about 1,100 people in the cohort, and the y-axis, and then the x-axis represents time. So the panel on the left is the 12 months leading up to a sepsis hospitalization, and the panel on the right is the first 12 months after the sepsis hospitalization, starting on the first day after hospital discharge. So each pixel essentially in this figure represents a different day and time. So for any given day, blue represents the proportion of this cohort that are at home, and red represents the proportion of the cohort that are admitted to an inpatient healthcare facility, so either a hospital, a long-term acute care hospital, or a skilled nursing facility. And certainly you can see that the total amount of red, or the total healthcare use for this cohort, is much greater in the year after sepsis than the year before. And moreover, if we look at the proportion of sort of their days alive that are red, it's a much greater amount of time spent in a healthcare facility in the year after sepsis. This figure has also brought up some new questions. So first question is, well, gosh, there's a lot of this increased healthcare use really concentrated to those first 90 days after sepsis. What is happening during those 90 days? And then another observation is, well, gosh, there's a very high rate of mortality among these people who survived their initial sepsis hospitalization. We know these are older folks, so they were over age 65, average age in the 70s. They have some comorbidities. They had a sepsis hospitalization. But nonetheless, 44% of this cohort is dead within 1 year, which is a very high number. And so trying to unpack that a little bit. So for the remainder of the talk, I'm going to basically talk about some work that I've done trying to answer or address each of these two different questions. And I'll start out with what is happening in the first 90 days after a sepsis hospitalization. We know from the study that a lot of this healthcare use is time spent in post-acute care facilities, so long-term acute care hospitals, skilled nursing facilities where people are sent to sort of recover after a hospitalization. But there's also a very high rate of hospital readmissions. In this cohort, about 40% of the patients ended up back in the hospital within 3 months of going home. And that's been seen broadly in other studies throughout different healthcare settings in the US. This study here looked at all discharges in the state of California for sepsis diagnosis. And this included younger patients, so all adults ages 18 years and older in the state of California during these 3 years. And so they find a slightly lower rate of readmission, which is understandable considering that it's a younger cohort. But nonetheless, a full third of these patients come back to the hospital in the next 90 days. And again, this has been seen in other healthcare settings as well. And this raised some other new questions. So what are people coming back to the hospital with after sepsis? About a year and a half or 2 years ago, I had done a systematic review looking at literature examining readmission diagnoses after a pneumonia hospitalization, which is a current sort of interest within the United States because we have penalties for hospitals with high rates of readmission after pneumonia. And during this process, I'd also looked into literature looking at readmission diagnoses after sepsis, knowing that pneumonia is the most common cause of sepsis and that that literature might be informative as well. But the interesting thing was about a year and a half ago, there was literally no studies that I could find published that talked about readmission diagnoses after sepsis. So this epidemiology was really unknown at this time. And so I wanted to answer that question. And then the second question is, to what extent might these readmissions be preventable? We know there's a very high number of them. Is there any evidence or suggestion that we might be able to reduce this number with some sort of intervention? And so to answer these questions, I again looked at the health and retirement study. By this point, I now had a little bit more data available. So all of the sepsis hospitalizations through 2010, in total, to about 2,600 sepsis hospitalizations where the patient was discharged alive. And I looked at all of the hospital readmissions in the next 90 days after people went home with sepsis. And here are the top 10 most common reasons that people come back to the hospital. Number one most common reason is that people come back again with sepsis. Full 6% of this cohort comes back at least once with sepsis in the next 90 days. You can see other common reasons for readmission here are congestive heart failure, pneumonia, acute renal failure, rehabilitation, respiratory failure, complications of the medical care they've received, COPD exacerbation. Sort of interestingly and unexpectedly, for me anyway, aspiration pneumonitis was a top 10 reason that people came back, which I think really underscores the importance of weakness in this population of patients. And then lastly, urinary tract infection. In total, these 10 diagnoses accounted for over half of all of the readmissions among patients who were discharged with sepsis. All right, so the next question was, how many of these readmissions might be preventable? And to try to answer this question, I borrowed this definition that's been sort of existed in the literature since the early 90s of this concept of a potentially preventable hospitalization. And so this has been defined as a hospitalization that could potentially be avoided if ambulatory care is provided in a timely and effective manner. Or more specifically, it's been described as diagnoses for which timely and effective outpatient care can help reduce the risks of hospitalization by either preventing the onset of an illness or condition, controlling an acute episodic illness or condition, or managing a chronic disease or condition. So the important take-home for this definition is not that all of these hospitalizations can or should be prevented, but rather that there is a possibility that they could be prevented. So these are conditions where there's a prodrome and there's an opportunity to provide some treatment in the outpatient setting that prevent things from getting worse and ending the patient back up into the hospital. These are also sometimes described as ambulatory care sensitive conditions. So specifically, the 16 conditions I looked at are listed here. The first 12 are recognized as potentially preventable hospitalizations by the U.S. Agency for Healthcare Research and Quality, so there's been really little debate about those, which have been broadly recognized and used as performance measures within the U.S. The other 4 in red were ones that I also added for this study after ensuring that they met all of the components of the definition of potentially preventable hospitalization from those initial studies describing this concept in the early 90s. All right, so then a little bit more about the methods here. So in addition to determining what proportion of readmissions after sepsis are potentially preventable, I also wanted to provide a comparison cohort to provide some context to this number that we'll find. And during the course of peer review, we went back and forth a fair amount about what is the appropriate comparison cohort here. And ultimately, we settled on hospitalizations for the 15 most common non-sepsis acute medical conditions. There was a lot of concern that people didn't want comparison hospitalizations that were for routine surgeries because it felt like that was like sort of too wimpy of a comparison. So this is what we settled on, these 15 different medical conditions. And then to further sort of level the playing field and make sure any differences that we measure are really due to the sepsis and not due to baseline demographics of these patients, I also matched these comparison hospitalizations to the sepsis hospitalizations one-to-one by age, gender, the comorbidity burden, functional disability of the patient prior to hospitalization, which we had from the health and retirement surveys, and also the length of their hospital stay. All right, so here this figure shows the proportion of patients over time who have any hospital readmission, and then the proportion of patients who have a readmission for a potentially preventable diagnosis. So again, we are struck with this very high rate of hospital readmission, a full 40% of the patients readmitted, even including this more recent data. And then 1 in 5 patients come back at least once with a potentially preventable hospital readmission. In total, when we look at all of the hospitalizations in the 90 days after sepsis, we find that about 42% of them are potentially preventable, compared to about 37% after these comparison hospitalizations, so slightly more. And I think suggests that there is an opportunity, a potential opportunity here to try to reduce the rate of rehospitalization with better ambulatory care or better transitioning of care from the hospital to the outpatient setting. Another sort of interesting finding from this study was just simply the differences in the reasons that people come back to the hospital after sepsis compared to other types of medical hospitalization. So much higher rates of readmission for sepsis, acute renal failure, respiratory failure, and numeric difference in sort of signal towards increased readmissions for aspiration pneumonitis. So interim conclusions here, I think I've beat the point home here that readmissions are very common after sepsis. Many of these readmissions are for potentially preventable diagnoses, and we still need to figure out to what extent these are actually preventable in real life. Another sort of interesting thing here is that the top 10 diagnoses account for over half of all of these hospital readmissions. So where do we go from here? So I think that this high concentration and prevalence of readmissions for just a small handful of potentially preventable conditions suggests that we might be able to design interventions that really focus on people's personalized risk for a few different common and potentially preventable conditions. And so I currently have a grant now where I'm developing risk prediction models for people's risk of coming back to the hospital with infection, heart failure, COPD exacerbation, renal failure, and aspiration pneumonitis. And the idea is that this risk model would be given to primary care doctors at the time that the patient leaves the hospital to try to give some kind of information about what is the biggest threat to this patient to try to help inform care in those sort of vulnerable first weeks to months after people go home with sepsis. Right now in the US, we focus a lot of energy trying to get people back to their primary care doctor in the first week or so after they leave the hospital. But we seem to spend a lot less energy thinking about what should happen during that visit. And I think currently a lot of what happens is simply a rehashing and sort of getting caught up to speed on what happened during the hospital stay, sort of commiserating with the patient, and less about specifically changing aspects of their medical management. So the idea here would be that if a patient has, the biggest risk for them is heart failure, you would want to make sure that you look at, the beta blocker or the ACE inhibitor that might have been appropriately stopped during a sepsis hospitalization and figure out if now is the right time to resume that. Or if people have a really high risk of coming back with renal failure, perhaps those patients should have some lab work monitored over time. So stay tuned. This grant is just getting started, but hope to have more data on this and sort of how well we are able to develop these risk prediction models and how well we're able to stratify patients and whether this actually changes outcomes going forward. All right, so back to this same figure in the second question, which is, wow, the very high rate of mortality in this year after sepsis. This study, too, had a comparison cohort, which was non-sepsis hospitalizations, matched one-to-one on these various different characteristics: age, gender, disability, comorbidity burden, length of hospitalization, and whether or not they were used the ICU during that stay. And even after matching all of these different characteristics, there was a much higher rate of mortality, 44% mortality in the year after sepsis, compared to just 31% after these comparison cohorts. And indeed, this has been seen in other studies as well. This is an older study by Corton, but a very elegant study that compares patients hospitalized with sepsis to matched patients hospitalized with other non-infectious conditions. And they do some adjustment to try to balance the comorbidity burden among these patients. And he finds that mortality remains elevated for up to a full 5 years after the sepsis hospitalization. So even people who survive, get this to work, to a full 2 years after sepsis hospitalization still have an increased risk of dying by year 5. But anytime you're dealing with observational data, I think the question sort of always remains, is this just residual confounding? And indeed, this study really wasn't able to adjust for a large number of confounders. And other studies have explicitly asserted that, yes, this is just due to residual confounding and differences in the patients at baseline. So this study here that looked at a very large, like 1,300 different patients hospitalized with community-acquired pneumonia, they found that after adjusting for baseline health-related quality of life, acute organ dysfunction was not associated with mortality or health-related quality of life at 90 days. And so the authors here conclude that these risks of poor outcomes are predominantly due to poor baseline risk, baseline status prior to illness, and not due to the organ dysfunction per se. And so we're sort of left with this question, well, what is the effect of severe sepsis for patients who are really indistinguishable prior to their acute illness? So as we have this very rich information on these large number of patients in the health and retirement study, I thought I might be able to see if I can try to do a little bit better job of trying to really match people and make them indistinguishable at baseline and try to measure what is the effect of sepsis on early but also late mortality and try to unpack it a little bit to figure out what is driving any differences in mortality. And so for this analysis, I drew 3 different comparisons. This figure here is from the initial Bone et al. Definition paper for sepsis, severe sepsis and septic shock. And I'll use this to explain the 3 different comparisons that I'm drawing here in this study. The first is comparing people with sepsis to people who are not actively in the hospital. The idea here is to understand, well, what is the effect, the mortality effect of sepsis compared to people not in the hospital, sort of including the hospitalization itself. Next comparison was people hospitalized with sepsis compared to people hospitalized with a non-sepsis infection, so no organ dysfunction. Asking here, what is the incremental effect of sepsis above and beyond people who are already hospitalized with an infection? And then the last comparison is to people with sterile inflammatory conditions, things like trauma, burns, pancreatitis, acute exacerbations of collagen vascular disease, things like that. Asking here, what is the incremental effect of infection above and beyond people who are already hospitalized with a sterile inflammatory condition? All right, so we start here with this health and retirement study, about 20,000 patients who have their Medicare linkage. And then I pulled out people who had hospitalized with sepsis. You'll see this number is a little bit lower than in some of the primary studies. And that's because we limited this to people whose sepsis hospitalization was immediately following their most recent survey. And that's because when we want to adjust for all these baseline characteristics, you want to make sure it's relevant information. So these people don't have any intracurrent hospitalizations between the survey and when they come to the hospital with sepsis. And then we also pull out potential comparison patients, people who are not in the hospital, people in the hospital with non-sepsis infection, and people in the hospital with sterile inflammatory condition. And then we match them, and I'll get a little bit more into exactly what we matched them on. But there were 777 pairs of people with sepsis compared to not actively hospitalized, 788 with sepsis compared to non-sepsis infection, and then 544 sepsis compared to sterile inflammatory condition hospitalizations. And here are all of the different characteristics that we were able to match the patients on and ensure that they were indistinguishable at baseline. So demographics, their healthcare utilization. This looked at number of hospitalizations in the prior year as well as prior sepsis in the year prior to their match. Their economic status, this included their wealth and also whether or not they were receiving government assistance to afford their food. Their health status, this included functional limitations as well as a self-rating of health on a 5-point Likert scale, which is highly predictive of mortality. and then also their comorbidity burden, their total burden, and as well as select particular comorbidities. And so here, this figure shows the results here of the odds of mortality among these 3 different matched comparison cohorts. As you would expect, for early mortality, this is within the first 30 days of these hospitalizations, significantly increased odds of mortality among people with sepsis, and these modest increases in mortality in sepsis compared to hospitalizations for these other components of sepsis. But then, of course, the interesting thing here is the late mortality. So these are of people who survived to 31 days. What is their odds of mortality in the next 2 years? And you can see that people with sepsis still have a 3.5-fold higher odds of mortality in the next 2 years compared to people not in the hospital, and still have measurable increases in mortality compared to people hospitalized with either infection or a sterile inflammatory process. This is results from the same model, but just presenting the data a slightly different way. These show the absolute increases in mortality. So essentially this can be conceptualized as mortality in sepsis, subtracting out mortality that the comparison cohort already had. So here you can see a 22% absolute increase in late mortality in people with sepsis compared to those not hospitalized. Essentially that means for every 5 people who had sepsis and survived to 31 days, 1 in 5 of those will die in the next 2 years that otherwise would not have had they not gotten the sepsis hospitalization. And then further we went on to look at different subgroups, so different subtypes of sepsis, looking at different types of infection driving the sepsis, different age, different gender, different self-ratings of health, comorbidity burden, functional limitations, whether or not the patient was residing in a nursing home or not, and really weren't able to find that this effect was isolated to a particular subgroup of patient with sepsis, but was really fairly consistent across the board for these different types of patients with sepsis. So the interim conclusions here are that sepsis is associated with substantial excess mortality and that this excess mortality persists up to 2 years that we measured in this study, and that this excess mortality is not different by different subtypes of sepsis that we measured. All right, so overall conclusions for my talk: there is substantial healthcare use after sepsis with frequent hospital readmissions, many of which we may be able to prevent, and that there's also excess mortality following sepsis that persists for months to years. I think that this data suggests the opportunity to tailor our post-sepsis care to target patients' risk for these common and potentially preventable readmissions, and I think this very high burden of late mortality suggests that we probably currently underestimate the burden of sepsis mortality when we just look at acute hospital mortality or 30-day mortality, which is what many studies do. And I think it remains to be seen whether we're going to be able to move the needle in terms of this late mortality. Obviously, reducing sepsis and treating sepsis early will help, but among people who have already survived a sepsis hospitalization, one of my hypotheses is if we're able to prevent some of these initial rehospitalizations or medical decompensations in the first few months, we may be able to make a difference in terms of people's subsequent mortality. All right, so I'd like to thank you guys all for your attention and thank the organizing committee again. I'd like to also thank my mentor. I have not been under-mentored, as well as my collaborators, my data managers and analysts, and then also my funding sources. Thank you.